sort of chairing this webinar with Caroline Kabaria, who is from APHRC, the African Population and Health Research Centre based in Nairobi. And I'm sure loads of you are really familiar with APHRC's work. They've been working in informal settlements in Nairobi for many, many years, and have sort of some of the best data anywhere on informal settlements over many years. So some really great publications from the APHRC team, Caroline included. And Caroline's background is in geoinformatics and spatial epidemiology. So Caroline is also on our Consortium advisory group for Chorus, and is just really brilliant at bringing those perspectives from informal settlements, but also giving that kind of viewpoint of different methods around using kind of geospatial mapping, and how those approaches can be really used to try and trigger change and improvement in informal settlements. So Caroline is going to present some of the work that she's been doing with local government in Kenya, using mapping data to really kind of inform health system improvement, and really bring that data into the information systems in cities. So we're going to have a presentation from Caroline first, and then we're going to go into breakout rooms by country teams, and we'll have about 15 minutes where you can discuss any mapping work that you've been doing already, or your plans for mapping work, how that's gone, and whether there are any sort of capacity needs within your teams around mapping. And then there'll be some time for you to feedback for the plenary, and if we need to, this is something we can bring up with the capacity strengthening team as well, if this is something where we identify areas where we might need a bit of you know, a bit of extra capacity strengthening across the teams. So I think with that, I'm just really happy to hand over to Caroline, and yeah, Caroline, take it away.
All right. Good morning, Helen. Good morning, everyone. Helen, thank you for that great introduction. It's really lovely to have you all here this morning, despite the challenges that we are all experiencing across the world. So as Helen has introduced me, my name is Caroline Kabaria. I am a researcher based in Nairobi, Kenya, working for the African Population Health Research Center. In particular, I work with the urbanization and well-being team, where we look at the challenges facing, the various challenges that face urban populations. And most of the times, when you think about inequities, you always end up with the urban poor, who are mostly living in slums. And for that reason, most of the work we do and outputs are usually focusing on slums within urban centers, both in Nairobi and across the country. So for today, I have a presentation where we want to just look at some aspects of community mapping and the application to health services. So I just want to check that my slides are moving.
Yeah, that's fine.
All right, and I hope you can also hear me clearly.
Loud and clear.
Great. All right. So today's presentation, I have titled it Community Mapping and GIS, and I'll try to focus this on applications for health research. I'll try to touch at the beginning on just the background of why is it important to map slums, and then I will move on to some examples we have done. I find it easier to explain based on work that we have done and some of the outcomes. So I will take less than 30 minutes. I'll hopefully not rush over everything. But if you have any questions, please do put them in the chat or hold. We can have a question and answer session just after my presentation and before the breakout, as explained by Helen. So why slum mapping? So you find a lot of slums are often hidden within official statistics. A lot of the health data we have only separates between urban and rural. And yet a lot of the population growth that is going to be experienced in the coming years is going to happen in low and middle income countries, and particularly in slums. So thinking about the case of Nairobi, where the population of slum dwellers is 60% of the city, it means then when you only represent urban and rural, then the slum statistics are often masked by the rest of the population within the city. So I'm displaying there a table. Sorry about that. So in the table on the right-hand side, it tries to show some comparison between data collected by APHRC within the slums in the first column, and this is compared to the demographic health surveillance data, both at rural, urban, and within the city. And as you can see, for example, if you look at the case of child mortality, within the slum from the APHRC data, it's close to, it's just about 40%. But then if you compare with what is displayed in the national data, you see this is an underestimated, where Nairobi itself is reported at 17% compared to a 14% national average. And even within the split of rural and urban, where urban populations then are reported to have a child mortality rate of 15%. So you can see that differentiation. Looking at, for example, vaccination of children, full vaccination for under 12 months, the same pattern is can be seen, where Nairobi itself, as the city, shows a very high coverage rate of above 80%, compared to the national average of about 83%. But from our data, the coverage is below 50%. So then that brings some questions, even in terms of planning for the county. So Kenya, our health service is devolved. Funding is given based on population and various indicators. So you might find the budget allocation, for example, for immunization, might not be so great within the city because coverage is seen to be averagely high. Yet within the slums, you have these pockets of low vaccination rates. And this is seen. So this was a cross-sectional slum survey, which was done in 2012, that was showing this kind of disparities. So then it makes it important then to, or rather makes the case of why it's important to disaggregate data down to slums. And if you have to think about the determinants of health in slums, then it's greater than just the individual. And based on this framework proposed by Richard Guilford at the University of Warwick, now Birmingham, there's a publication they did together with some researchers at APHRC that shows that the determinants of health of an individual are beyond the household, but are also a factor of the neighborhood of where you live. So typically, slums are classified based on, for example, household wealth. But what does it mean if your household seems to be better off than other households in a slum, yet the neighborhood, you are living in an area with poor sanitation, you're living in an area with open garbage disposal. So that to say that the health of a person living in slums then is a factor also of their neighborhood. So in that case, Richard and team proposed a structure of how then do you distinguish a slum area beyond just the household wealth. And they came up with about 4 domains, which are around the built environment, the availability of services, social exclusion, and the ecology of the environment that you're living in. Some of these can be derived from household data. Some can be derived within ground surveys, but then there are also opportunities to also derive these from Earth observation data and by extension, the Geospatial Information Systems, GIS, which I want to talk about today. So one of the projects that we've been working with, and Helen is part of this, is the Ideas Map Network, which we proposed through literature review, various domains of deprivation framework. So beyond the socioeconomic of the household, beyond the characteristics of the housing itself, there could be other layers that can describe deprivation within the city. I'm not going to read through all of them, but I have given a link here where you can learn more about the project. But then this expand, as you said, from the household to the area, so the environment in which the household is located, but also the connectivity with, for example, infrastructure, availability of services, governance. That are all these are factors that then influence the health of an individual, or the level of deprivation of a household or an individual living within a slum, for example. And how you can employ this within a geospatial framework is to then put this into layers, and you can come up with like a continuous map as displayed here. This is just sample data that ranges from the least deprived to the most deprived area. So you're able to identify them within a city block, for example, or within a city. So you can identify like the reds showing the most deprived areas, with assumption like they have most of from the indicators we saw in the previous slide. You can also reclassify the first image here to show what then you would call a slum or an unslum area. So and this is for different purposes. A city decision maker might be interested with, so what, at what percent, what's the threshold where you say if you're 50% deprived, then you fall in a slum, or if you are above a certain threshold, then you're not considered a non-slum area. So this can be interpreted by different, for different purposes. And additionally, then it can be overlaid on population metrics, and then you can say, perhaps people who, for example, the area indicated at the bottom here that I'm sort of stuck in, I hope you can see that, where there's the highest population that coincides with the most deprivation, then you can say if you're distributing interventions, where do you prioritize? So that is just an example. So coming on then to applications for health, I want to speak through a project that we did. So this was a project that was implemented in Nairobi, in Kenya, in Nigeria, and in Bangladesh and Pakistan. And it was implemented in slums. It was a project that was funded by the National Institute for Health Research, led by the University of Warwick, and APHRC was leading the work in Kenya. So then we worked with communities to try and map their communities first. So we did what we call the slum mapathon. So it's just like a marathon of mapping slums, where we worked with our staff and volunteers from the community. And we worked by digitizing the slums from satellite imagery. And I want to show you some outputs from that. So on the left-hand panel, you can see the digitization process of trying to identify the location of each structure within a slum. We also did some field work of tracking roads and footpaths using handheld GPS units. Those are the conditions when we were working. And then this was followed by a field verification. So what we mapped from satellite imagery, we went on the ground to actually verify that's the structure and the footprint of the buildings that we were mapping. And so some of the outputs, so this is this one slum in Nairobi called Korogocho where we were working. So before we started the project, what is shown in gray, that is what was mapped in that area. But through the process, we were able to update the location. So the yellow shows the footprints of all the buildings within the Korogocho slum. So as Helen had indicated, APHRC has been running a demographic surveillance system within these slums for almost the last 18 years. And so from this mapping, then it is possible to link every household to a spatial location. So you can identify where that is, where each household is located through this. So the others, in addition, you're able to capture information on the location of health facilities. So quickly, just showing the second slum we work with, which is Viwandani, still located within Nairobi. Before we started the project, what is shown in the gray is a footprint of what existed. And as we worked, we were able to update that to map all the buildings, all the structures that exist within that slum, and in addition, identify the location of health facilities. So in total, this is what we were able to add to the project. In terms of dwellings, we were able to map over 2,500 dwellings with about 7,000, close to 8,000 households, about 32 health facilities within the Korogocho slum. We were able to map an additional 8 kilometers of roads and add footpaths, about 125 that did not exist in that community before. The same similar statistics within the second slum, which is Viwandani, where we were able to map 4,200 dwellings. So these are the structures, about 13,500 households. We were able to map also the health facilities. Sorry, that is statistics from before. But I think we ended up with about 25 health facilities within that area. We were able to add some structures and road lengths. So through that participatory work with the communities. So how then do you enhance this for the purpose of health research? In addition to just mapping the health facilities, we're able to do a service provision assessment, so characterization of the health facilities. So in addition to the spatial locations, we're able to get information about labor, the number of doctors, nurses, community health volunteers linked to health to each facility, the spatial location in terms of capital, what types of drugs are available within each facility, the equipment, tests that can be done within the facility and the cost of each. We're able to get information on inpatient data and outpatient. In terms of the financial, how much it costs to access services, who owned and the opening hours of each of the facilities within that area. Further, then this was linked with household data within the same community. So then to analyze what are the patterns of health use. So we're able to get information on the household. So remember, we mapped the location of every household. So we're able to identify what kind of health needs and their preferences at the household level to then compare with the facilities that they are utilizing. So, and all this just works on the premise that the type of facility that is selected is both a factor of the household characteristics, the health facility characteristic, but again is a factor of distance. So not shown here, some of the results we're getting that a lot of the inpatient, like overwhelmingly, for both inpatient and outpatient services, people chose to select facilities closest to them, where so that distance to the health facility was one of the biggest factors, followed by maybe the costs and the amiability of the staff within within the health facility. But overwhelmingly, both for inpatient and outpatient services, people chose facilities that were closest to them. So I'm not sure how much time I've taken, but I can move again. So we were looking at this table earlier, and further to the results that we got, then it's important to identify what are the reasons for the gaps within, for example, immunization services, and then what resources are available so that you can be able to deploy interventions in a timely manner. And so we had some work which we worked with community health volunteers at the sub-county levels to try and help them. So the data we had already mapped of the households, then to identify what is the location of children, for example, who are not immunized or who are not fully immunized. And so this was work that was extended to even the city of Kisumu. So these are two slums in Kisumu, which is Nyalenda and Obuga. And the work was continued in Nairobi County, Korogocho, and Viwandani. So here is, speaking earlier to the comparison between what is shown as the city average immunization rates compared to the slums. So on the right-hand side, we are looking at coverage for DPT, the last dose. And you can see what is in written, which is a dark red, is the sub-county. So that's the admin 2 level coverage. So moving from the county level to the sub-county level. So at county level, you can see very high immunization rates reported in one of the sub-counties named Ruaraka, where Korogocho sits. So Korogocho sits across 2 sub-counties. So the rate is reported at 80%. And there's neighboring sub-county, which is Embakasi North, has an average, has a coverage rate of less than 50%. And this is very close to what is happening in the slum, which is Korogocho. So if you are to divide even by villages, and so what is shown in the slum is based on household data. And you can see still you have very low immunization rates. So if Ruaraka was reporting their immunization coverage, it might seem very high and may not have resources to actually expand this. Yet they have populations within their sub-county who are not, where the coverage rates are very low. So the same comparison is seen even for measles coverage. And so then the justification was then how do you work with the community, with the health system workers to try and identify where the children who are not fully immunized are located. And so we went through a process where we trained the community health volunteers on mapping the location of the households with children under 2 who needed immunization, and then checking their immunization status. So the community health volunteers are able to identify who is in need of immunization services. They would then make a referral to the nearest facility. And from the nearest health facility, now the sub-county team, which is part of the health system, would then pick up to see who actually comes. So if somebody was referred and they did not come, then the health volunteer was able to follow up to identify what is the reason why people are not taking their children for immunization. It also helped in planning for outreach services to try and improve this. So this is work that is still ongoing, but it's part of the work that we did was the GIS capacity training for the community health volunteers. So this was done both in Nairobi and in Kisumu. So further to this, we worked with county health information officers who are then charged with putting this data into the district health information system, the national system. And again, worked with them, building their capacity in trying to map, in working with the data in a sort of a spatial aspect, how to analyze and create maps of the various. So what you're looking at, for example, is Nairobi County, the various coverage rates. So that was part of our GIS training that we conducted. So what are some of the lessons we have learned? So one of the things is the frequently changing slum environment. So for example, we said we did map the structures and the households, but there's a very high rate of change within slums. And this is even not just in Kenya. I imagine it happens even in slums across the world. So where today you would map a household and you come tomorrow, the usage has changed. Maybe it's now a commercial structure, or the households have moved. So about 20% attrition noticed within Nairobi slums. Then there's a consideration of costs. So if, for example, you're recommending this to be taken up by cities, are they able to afford, for example, the cost of satellite imagery? Or if they're using for free imagery, the resolution sometimes might not be very high to map, like for example, urban environments, the structures, the slum structures. Then of course, there's a need of capacity building within city departments. While you're working with slum communities, then you need, how do you keep a cohort of slum residents who then have mapping skills to be able to regularly update? So we're able to do this through the project funding, but beyond project funding, how do you keep the slum community engaged to continue mapping where new structures come, or the use changes, So that's one of the considerations when you're doing this. And of course, there's also the need of engaging various levels of government. So the government agencies, the slum community members, as well as other stakeholders. So I've walked through a lot of work done through different projects, and these are part of the participants who, of course, I acknowledge their participation. And with that, I can briefly stop there. Thank you, and over to you, Helen.
Brilliant. Thank you very much, Caroline. That was really, really interesting. I think we're going to have a lot of questions and good discussion, particularly on kind of engaging the sub-county and the county teams in the whole process, because I know that's something chorus teams are really keen to do, particularly in the next phase of kind of intervention, co-design and implementation. So incredibly interesting. We had some questions coming up in the chat, and I wonder if we can just have a few minutes just for people to ask anything to clarify. Irene, I can see a lot of your questions coming through in the chat. Do you want to just go ahead and ask them rather than me repeating them?
Sorry, yeah, thank you, Helen. Yeah, thank you, Caroline. Excellent presentation, very interesting. I just had questions as I was trying to follow you and understand the data. It's not the method, which I think is great. I think the first one has been answered because you were talking of the issues about immunization coverage, and often mortality in the child age group is related to interventions like immunization and so on, whereas neonatal mortality is related more to interventions for maternal health and around delivery and so on. But I still thought it was interesting that actually your neonatal mortality rates are lower in the slum than, you know, in the Nairobi as a whole, national, rural, urban, whichever way you looked at it. And I really wondered, you know, what might, because we are kind of looking at inequities both ways, and it might be that there's something everybody else could learn from the slums. I really don't know. And then but the post-neonatal mortality rate actually rises and becomes, you know, the same picture as everything else. I didn't quite understand it. And then the other one was on the mapping, which again was great, showing the low coverages, but I wasn't sure I heard clearly. You were saying you used a survey for the slum areas, but for the county data, was it also a survey or was it the routine data? Because sometimes, depending on how accurate the routine data is, it can mislead quite a bit. Thank you. But great presentation. Thank you so much.
Thanks, Irene. Caroline, do you want to go ahead and answer those ones, and then we'll see if there's other questions?
Yes, and so thanks for that. And I've you've picked up on the points of discussion that then we had with the sub-county or the county departments. So yes, you are correct that the data from the sub-county is actually routine data, which is collected at the health facility level. And this is compared to what we are doing at the household. So the concern actually, even for the county officials, is if our routine data is showing very high coverage and yet the households are not immunized, what is the most important thing to do? So one of the reasons that could explain this is about how routine data, they estimate their population to be served. So they'll normally take this from the census data. So census data, they'll project what is the number of maybe underones. And they'll then say our target, for example, by this facility is 3,000 children. And then they'll compare by how many children they actually immunize within that period. But as I started from the beginning, the census itself does not distinguish between slum and non-slum populations. So if they're underestimating the population, it means then they're also underestimating the number of children who need to be served. And sometimes it's not shown in this, but you'll find even there are other areas where they have immunization rates above 100%. So then it brings the need then for the counties to extend beyond just routine data at health facility, or then how then do they link this to population data? And that's part of the ongoing is the error in the estimation of population that needs to be served. So that when you serve 2,000 children, it seems that your coverage is very high, yet you underestimated the population that needs to be served. And this is historical in that slums sometimes are not even included as part of official statistics because of their deemed illegality and so on and so forth. So maybe that just touches, but it's some of the things to even think about when you're thinking about health service provision, how the data is even calculated or estimated. And this was part of even the training with even the sub-county health information officers, because then they're the ones who are charged with the population counts or the population estimates. So when you're reporting a very rosy picture, yet at the household level, the data is different, then as a government or a government agency that is planning, there's some disconnect that needs to be closed. I hope that answers your question. Now, back to the table on the neonatal. I'm actually maybe going to defer. I'm not an expert in that area, and those are just the results that were observed. So I don't want to comment too much on that. There might be people here who might have a better explanation. I'm not sure if that is satisfactory as an answer.
Yeah, Caroline, it is a really interesting one, isn't it? And one that's sort of worth exploring, like where are women delivering? What's their access? What is going on there? Is it, I mean, could it also be a reporting issue? I don't know. Yeah, it'd be great to hear if anyone else has any other possible explanations they'd like to share. Please do just jump in. Yeah, and Deepak's pointing out the different methodologies and the challenges of sort of comparing different surveys and well, obviously in routine data. So yeah. Tim, I can see a question from you in the chat. Would you like to go ahead and share that?
Yeah, thanks, Caroline. That's really interesting. I was struck by what you said about the speed of change within slums, and you mentioned 20% attrition. And I had two questions. One was a small one, which was over what period is that? Do you mean that 20%? How quickly is that change happening? And then do you have any tips on incorporating change into your models? Because I guess you did this participatory modeling maybe once, or maybe you have to do it regularly. Just your experience on that would be interesting.
All right, so as I mentioned, that the slums that we're working with is also the area where we have the urban demographic surveillance system. And so the reported rate is both in from the demographic, from the DSS data. So how often people are coming in and out of the slum, and how often the change of use of the structure is where the 20% is coming from. There is really, so this can be accounted for. So for example, when you're doing your sampling, when you are sampling for the household survey, it means then you oversample by 20%. And in terms of period, previously we collected data 3 times a year. We are now collecting it 2 times a year. So that's within a 6-month period that you have the 20% attrition rate. I hope that answers your question. In terms of modeling, I guess maybe one way I've given an example is when you are sampling for data that you overestimate by about 20%, because you're likely not to find households that are in your sampling frame at the same rate. I don't know if you had further thoughts on that, Tim.
No, I mean, you've kind of answered to some extent. You've answered the question, I think, because you're saying you're looking at these areas two or three times a year. So you're going back to the communities very regularly, which is interesting. I guess it's quite resource intensive, but if you're going back to those communities 3 times a year, that shows how much change is occurring, I guess.
Right, and it also speaks even to the mapping challenge, that the data you have is only valid, so you cannot take data maybe every 2 years. So it means there's the need for a lot of investment in that area, and as you mentioned, even the resources that would be needed to do that.
Yeah, thanks.
Our team's question is reminiscent of the ongoing debate on whether maps are static maps or whether they can be more dynamic maps that that can then be viewed and visualized depending on changes in utilization of services, whether that be seasonal changes or even the busyness of the day, you know, when traffic is very heavy in the morning or during festivals. Do you see such variation in utilization of services, either seasonal or over time? And if you do you have just one map showing was such change, or do you have a number of maps based on those periods of the year? Over.
All right, I would say the most useful would be the dynamic maps, and the question then is about the investment in time and resource in keeping this updated. So when we were working with the first project I spoke about, we were using the OpenStreetMap community, which brings together volunteers who are regularly updating maps, but this is purely on a voluntary basis. So when we were working with the communities, we try to train, and I think that's what brings to me part of the lessons learned. The second bullet I have here, how then do you sustain? So the OpenStreet community, anybody can enroll, you could enroll. We have active communities, mostly youths, working across the world who, for example, I could set up a project and they could come and contribute, but all this then is voluntary. So how do you make it sustainable? There's that proposed model that you have people who update the maps continuously, so that then the map is dynamic if you wish, but there's the question about cost and the resources of how to do that. So that is something that maybe we are all learning, and maybe even the Chorus team can answer that. What is that model that can be able to update these maps that regularly? Over.
Thank you.
Thank you, Caroline. I can't actually see if there's any hands up. So I think if there's like one more urgent question, if not, we will move into the breakout rooms. Is there anybody else who's got a burning question they'd like to ask?
Hi, Helen. Cecile here.
Hi, Cecile.
This one, I mean, I understand in case of slum mapping that in our case, we don't have big slums. But what happens is urban poor households are spread across the city. That makes really life difficult in terms of really tracking them in mapping process. I was wondering if, Caroline, you have any this kind of examples, or how do we really take into account all the slum households, the poor households, urban poor, residing outside the slum area in mapping process?
Yeah, so that's a tough one, and I don't know if Helen. I think it goes back to the sort of the ideas map thoughts that I presented at the beginning about defining contiguous areas. Sorry, I'm trying to go back to that on the slides. So where, as opposed to containing a slum to a geographic area, you have a continuous surface of deprivation based on different aspects. So that in the end, what we define as a slum area would be a high concentration of this, but then it's possible to have those definitions of households that meet the criteria of deprivation at different percentages. There's a question, I think, even within the idea maps where we thought, how do you define that threshold? What does it mean to be 20% deprived as opposed to 25%? What does it mean to be 50% deprived as opposed to 70%? Helen, any thoughts on that?
Yeah,
Sorry,
I mean, it's a really, that's fine. I mean, it's a really challenging one, and Sushil and the team in Nepal were sort of active in the surveys for urban equity studies. They worked a lot with Dana on using world pop data, particularly to do the kind of sampling frames for surveys to try to, you know, look at density of population per grid square, etc. But it is really challenging because how small can you go? And sometimes there's little pockets of poor households are really hard to identify. And it's not just in terms of, you know, identifying them for their data, but it's also for health services to be able to target those small sort of pockets of poverty. So I think it's a really, but yeah, as Tim's just put in the chat, really important question for Chorus. How do we deal with that when we've got those really mixed neighborhoods? Yeah, so another key question I think for us to consider as we go forward in Chorus. Any others? Sushil, do you have any other ideas on that one? You're immersed in those questions.
Well, thank you, Helen. Thank you, Karen. I mean, there is no one fixed answer, I guess. Perhaps we shall continue to explore in Chorus, taking most of these cities as an example in a small area and deploy fully appropriate methods. I bring here the more importance of community engagement in terms of really tapping these various types of deprivation in neighborhoods. That can be different. For example, in our two major cities, Pokhara and Kathmandu, we may need to deploy, looking at the types and characteristics of the city population, we may have to come up with different strategies to map these households. Challenging, but I don't think it's not terrible. Let's take it as one of the key areas. Tim also says that this might be the case in most of the cities that we work with in Chorus. So we shall have a focused discussion and come up with some approaches that can be piloted based on the SU learning as well as the the idea map network work that you guys have been doing. Yeah. Over to you.
Thanks, Sushil. And I also just want to plug another webinar that we've got on Thursday the 7th, where the Idea Maps team or members of the Idea Maps team are going to present some of the work behind this domains of deprivation framework. And we've also got the UN Habitat team will be talking through, they're trying to develop a participatory slum upgrading index. And they've been working on that over the last couple of years. So they're going to talk us through that in the webinar as well. So if you're able to join on Thursday, that would be really great. And we can talk about this in a bit more depth. I'll put the link in the chat. But I think we should move on to the breakout rooms.